mind if I sit here?
That's fine.
Okay. I'm just gonna look at my list.
Mm-hmm.
Okay. So can you just start by introducing yourself for the camera?
Sure, my name is Ann Murphy, and I'm a pediatric cardiologist.
Okay. So what inspired you in the beginning to really get into cardiology, and why was going into the field of cardiology one of your aspirations?
Yeah, this is when I was a resident in pediatrics. I got to work with pediatric cardiologists, and I thought what they were doing was really cool and really exciting. That was a time, congenital heart disease was really taking off. It was also when interventional cardiology in children was just starting. And those two things together really got me interested. I used to escape from other rotations to go down with the cardiologist to the cath lab because it was just cool.
Because that time the innovation was just at an all-time high. We were moving towards.
Mm-hmm.
Was that moving towards open heart?
No,
was
well,
that
they were
well past?
already doing open heart.
Yep.
Since I think, the Blalock Taussig shunt was in like the 40s. Open heart in children more in the 1950s to 1960s.
Yeah.
And then the world just exploded with very innovative heart surgery, including lesions in the heart that we didn't think we could fix previously. The interventional cath lab procedures also really started in the 1980s.
So is that the 1980s? Was that really I don't want to say the peak, but is that when most of the surgeries that are performed now were invented, or?
Mm-hmm. I think the surgeries were were started in a stepwise fashion. Initially, what they were doing was palliative. It was sort of keeping the kids going, but not really correcting the heart defects. And gradually over the late 50s, 1960s, and even 1970s, these surgeries were really matured.
So I talked to Dr. Vercella, and
Mm-hmm.
he said that they have knocked it down from a 6-hour surgery, and he does it now in 3 or 4.
Mm-hmm.
Is that just a progression of time, and that they've upped their surgical prowess, or is that just the linear progression from it was hard now and now it's become easy because it's done more often?
I think they were really sort of sorting out the procedures and how to do them initially, and then they got better and better. There were also procedures that were further, how can I put this, matured. Over those years, they paid attention to fine details to avoid complications.
Can you kind of just describe what the historical significance was at Hopkins versus in other places?
Well, Dr. Taussig had the idea that she can make, or her surgeon, Dr. Blalock, could help improve the status of patients with cyanotic heart disease, that is, kids who are blue. Now, not all kids were blue for the same reason, And I think they were on a learning curve for that. But she recognized, and if you read the original paper, that there was less, the kids who had decreased blood flow to the lungs would benefit from the shunt from the aorta to the lung artery. You know, it was a big stretch.
Yeah.
I think she was very persuasive with Dr. Blalock,
Yep.
who is a fantastic surgeon in general, but I think he had to be persuaded to give it a try.
Because I read a quote from a guy at Harvard, the Harvard professor, who was like, it has been deemed that people who want to operate on the heart should be shunned by their colleagues and never be allowed to perform surgery again. And to have Blalock go in and do it and have it be successful enough had to have been.
Yes, and I met Dr. Taussig a couple of times. She was a very strong person. She, because she didn't hear well, she tended to shout.
Yep.
And she would just be honest, and, she was not someone to be messed with. So I think it took her some time to persuade Dr. Blalock to do the shunt. But she was a persuasive woman.
So she got him to do it.
She was very strong, and she got him to do it. And she describes being in the OR when he got through, and it probably took him hours because they really were in uncharted waters. And then when they were done with the anastomosis and started sewing up the patient, she described she saw the kid's lips go from blue, like it was before surgery, to pink. And that was amazing. It drew a lot of publicity. Patients were coming from all over the place for the surgery.
So I found Dr. Richella's interview with the 5th or 6th blue baby who had surgery, Michael Sherman. And he hadn't had any surgeries following. He lived into his late 80s with just the shunt that they. Yeah. Is that if we're looking at the man who had only had just the primitive shunt as to what we can do now, are we expecting much more advancement in the future toward
I think the goal is for people to have really essentially normal lifestyle. Now, does that work out in everyone? No, because it depends on the severity of the pulmonary arteries being small, depends on their ability to take care of themselves and their health. So there are many factors. And if you look at patients from very low income, countries, they might just get the first surgery and that's it. Certainly many do pretty well, but it is not ideal, which is why we do a complete repair that basically fixes the physiology, not always perfectly, but as best we can.
Obviously quite enough that I can play water polo and Sadie can go run around Hershey Park, so it's working quite well.
Yes, it is, and that also is due to specialists in older teenagers and adults who've had congenital heart surgery. That certainly took a while for people to develop that expertise.
and to recognize that the care that we needed for adults with cardiac defects and illnesses was much different from what we would do for a baby or a teenager.
Right. There's relatively few defects that make everything perfectly normal when you repair them. Yes, that's why, patients come back.
Yeah. Do you think that having such a large difference in Vivian Thomas being basically a janitor for what his title was, and having Taussig be deaf and Blalock be kind of like their spokesperson, do you think that played a part in how quickly the surgery was done and performed?
Vivian, he may have been called a janitor, but Blalock recognized his expertise. So he worked in the surgical lab with Blalock. When this discussion came up of doing something for these patients, he was very involved in that. So he Taussig thought the shunt would help. So he was the one who worked it out, which was amazing when you thought of his circumstances in those days. But he was very good with his hands, and he was very bright. So he figured it out, and then he went through it with, this is what I understand, he went through it in great detail with Blalock, and they worked together until Blalock was ready to proceed with surgery on a patient.
When he worked with Blalock, he was working on animals, and they helped like that break down what the steps would be
That's
to perform the
right.
surgery on a person.
They helped them figure out, how to do it.
Do you see the future being more towards giving the kid, hopefully, just being able to do a cath and having that be the same as an open heart, or do you think that that's too complex?
I think there are actually people maybe trying to do that already.
Yeah.
I don't know enough about the latest and greatest in the cath lab.
Yeah.
But is that feasible? Maybe. But the surgery, as far as surgeries go, is pretty straightforward. Usually works well. And then, where people used to have second or third surgeries, that's the place for doing interventions in the cath lab.
I think that's mostly everything. I did have one more question. How do you think that wearing technology will continue to help proceed in cardiac technology? Like, do you think that having this as a baseline and being able to see heart rates, EKG, like this has a built-in EKG now, apparently?
Yeah, it can detect atrial fibrillation in particular.
Yep.
Yes, it is very helpful. Not so much for the kids' disease, but if they put a pulse ox on it, it would be. For adults, though, there's a condition called atrial fibrillation, which is where the top part of the heart sort of gets a bit irregular.
Yep.
This can detect that. And I have an older friend who that happened to, and that's exactly what I told her, and her doctor told her, if this goes off, call us, So there are technologies that are starting to be available that help people detect issues.
So you would think put a blood pulse ox in it. My dad's waiting for the insulin reading level. That's going to be the next big step for diabetes.
Well, that, kids is already used.
Yeah.
You know, they have, skin probes for glucose detection, and they can look at, things over 24 hours.
Yeah.
And make adjustments based on that. I don't know in adults whether they use that as much, but certainly for children with diabetes where it's a little tougher to regulate,
Yeah.
we're using that.
And it's less invasive. I mean, in my opinion, I would rather wear a watch than have a in-skin halter or whatever.
Mhm.
I think that's everything. Thank you so much.
That's great. It was wonderful talking to you. And keep up your curiosity and your learning, and who knows, you could be a doctor. That would be great
That's
from
the
my
dream.
perspective. All right.